Like, yeah, she was a bit sick over the weekend. No, I think she's getting better. Yeah, she slept okay last night. In and out. No, Josh is playing football. We're in the park. Okay, it's not raining at the minute. Okay, he's grand. Everything's fine now. Hopefully she'll sleep a bit better tonight. She had such a fever, but we gave her some Calpol. Josh! Josh! Oh my God! Josh! Are you okay? Help! Oh my God! Help! Someone!
I just seen what happened. It's gonna be okay. I'm gonna ring an ambulance now.
Please help! Oh my God! Make them come quick! It's gonna be okay.
Hi, what happened? Okay. What's your name? Josh, stay nice and still for me, okay? My colleague's just going to place his hands either side of your head. I want you to stay nice and still, okay?
Okay, Gav, see one.
Okay, open up the mouth.
What's your name?
John.
Okay.
Josh, okay, Josh. Okay. I'm just going to hold your head, okay?
Fast and shallow respirations, Tom, okay? I'm going to expose chest.
Gav is just going to cut your top here so we can have a look and see, alright? Can you remember what happened?
Got hit.
You got hit? Okay, alright. Tell me, have you any pain anywhere?
In my head.
In your head, okay. We're just going to have a little look now and see what's going on. Is that alright?
Yeah.
Well done.
Okay,
You're doing
bruise on the
really
left hand side, Tom. I'm going to have a listen, alright?
No catastrophic bleeding there. Okay. We're just getting you sorted there now, alright?
Get your warm now, okay? Take a nice deep breath in.
Well done.
Okay. Excellent.
Well done.
Okay. Freckles. Alright. Covering them up. Alright.
Okay, we're going to get you
I'm going to get him on some O2 now, alright?
Put a blanket on you to keep you warm, alright?
Just keep you nice and warm for a minute, okay? We're going to put you on some oxygen, okay?
What we're going to do is we just have a mask here. We're putting your face for some oxygen, alright? And it'll help you breathe a bit better.
Hi, Jared.
Hey, that's here. I'm Jared. This is Michelle.
Hello.
This
What
is
happened?
Josh. He's 11 years of age. Been hit by a car. He's been knocked
Well
about
done,
4
stick your head
metres.
down, well
Okay.
done.
ALOC.
Okay.
Marked contusions and bruising down the left hand side.
Okay.
Alright, here crackles on the left hand side. I'm going to get him on high flow O2.
Okay.
Alright, very cold.
Well done.
Okay, we
You're
try and get
doing
him out of here
really
as quick as possible then, yeah?
Okay.
We're going to look after your son now, okay?
You okay?
We're going to take your blood pressure.
Have a nice collar ready to go on.
Okay, whenever you want, I'm going to expose that down there for you.
What we're going to do now is we're just going to put a collar on your neck. Is that alright?
Keep your head nice and still.
Okay.
I'm gonna slide on
just
to you there,
help us
Gavin,
for
now, okay?
moving you. You're doing really well.
You're doing
okay.
brilliant.
That should be true to you now,
Well
Gavin.
done.
Yeah, it's going to feel a little bit uncomfortable,
Well done.
but it's just designed to
You're
stop
doing
your head
really
moving.
well. Just get that mask on you already. Okay.
Yeah, I'll fix it now.
His blood pressure is 86 over 60.
Okay, the collar's on,
Is
okay?
that okay?
We have Josh here, he's 11, he was hit by a car, high speed, he was thrown about 4 metres, so what we need to do is we need to get the
Yeah, it looks
scoop,
good, alright.
the stretcher and the vacuum mattress.
That's great. Well
That's
done.
okay.
Pelvis appears in stage.
patient, that's it.
We're going to get him into the back of the ambulance and we get him down to hospital and get him checked over, okay? So there's nothing to worry about, alright? He's alright, he's talking away to us, there's nothing to be concerned with, alright?
Blood pressure is 86 over 60, okay?
Okay, and his rest rate was 34.
Okay.
Just having another little look, we have an open fracture here to the left hand side, okay?
Okay.
Now, seesaw action, Michelle, okay?
Yeah.
We'll go up.
You feel that
Okay.
now coming under your backside,
Watch his hand here
alright?
now, Gavin. Can you just
Well
move his
done.
hand there a little bit
Yeah,
first,
no
please?
problem, Alon. Excellent, Josh, you're doing brilliant,
Once
okay?
more, okay?
Is that
That's
okay?
it, okay?
You can give me a hand with
Okay,
this
Josh?
fracture.
Well done.
Covered.
Brilliant.
Tom, will you tell him there's a little tightness here now when I
Use
sit
that bit
there,
of
okay?
tightness that I told you about. Feel it there?
Happy?
Well done.
Cover him back up.
Bandage in the bottom of the bag. We'll stabilise the fracture. We'll get him on the combi board onto the back mat, get him in the back of the ambulance, and then we carry on. Is that alright?
Any pain anywhere else? Okay, good stuff.
Josh, your mum is here as well, okay?
Okay.
She's not far.
I'm grand, thank you, yeah.
Now crackles on the left hand side, alright? Still there.
Okay.
Everyone ready?
Yeah, we're ready.
Prepare to roll and roll. Okay,
Okay.
ready? Prepare to roll and roll.
Okay.
Okay, ready?
Yeah.
Prepare to roll and roll. Prepare to roll and roll.
Okay.
Well done. Prepare to lift and lift. Here we go.
Okay.
Well done, Josh.
Okay, Josh is off the combi board now.
Okay.
We've reassessed.
Yeah.
We've got the go-ahead off Medico for TXA, so we get the TXA going, and then we'll discuss some analgesia for Josh. How's that sound? All right. Okay. All right, Josh. Just stay nice and still. We're going to look after you. Okay.
Abscess.
We're going to give you some
08,
medication,
21.
and we're going to get you something for the pain.
Indeed.
Okay. In days. Okay.
Yep.
500 milligrams and 5 mils.
And we're going with 600 milligrams as per medical.
Okay.
Okay. So, pain relief.
Okay. Let's start.
So, can't give intoxiol to level of consciousness.
Yeah.
Entonox chest injury rules it out.
Okay.
Morphine, the blood pressure on that reassessment there, 86/60.
Wouldn't be happy with that.
No. Has we look at some intranasal fentanyl.
Yeah.
Um,
We have IV access
Yes.
now. Okay.
So maybe look at some IV paracetamol,
Yeah.
and then maybe some ketamine.
Yeah.
And
We'll
there we
discuss
go.
that now. We'll get the TXA
Okay.
running first.
We get TXA running. We'll work out our calculations. We'll work them out with being 40 kg in weight.
Okay.
All right. Happy enough.
TXA
Okay. TXA.
in a 100 ml bag.
We start paracetamol.
Paracetamol, yeah. So
Okay. So it's 40
kilograms.
kg. Yeah.
Yeah.
So 15 per kilogram, so 600 milligrams. We're going to do that IV, yeah.
And
Okay.
Medico Corp approved that as well. So
Yeah,
we're happy
happy with
enough.
that.
Okay.
Because we're going to give you something for the pain now. Is that okay? Yeah. We start running the paracetamol and see how we go.
Yeah,
Okay.
okay.
We'll keep an eye on the blood pressure continuously.
Yeah.
Okay.
So we'll let the TXA run in for a few minutes, reevaluate, reassess.
Yeah.
Okay, Tom, we're ready to go here.
5-4 to control.
Go ahead, Delta 5-4.
Control, we have an 11-year-old male involved in an RTA hit by a car travelling at approximately 80 kilometres an hour. There's a bullseye to the windscreen of the car. He has an obvious injury to the left side of the chest with crackles on auscultation. He has a compound fracture to the left radius. He has an altered level of consciousness. His pulse is 140, rest rate is 34, BP is 84/60, his GCS is 14. He has been administered 600 milligrams of TXA and 60 millilitres on scene, and our ETA is 10 minutes over.
Roger that, Delta 5-4.
Hello, Temple Street receiving.
Hi there. We have an 11-year-old male hit by a car at approximately 80 kilometres per hour, bullseye to the windscreen. Bruising to the left side of chest with crackles and oscillation. Also bruising to LUQ. Heart rate is 140, BP 84/60, rest rate is 24. He has a GCS of 14, and we administered 600 milligrams of TXA on site. ETA 10 minutes.
Dr. Quinn, we've had a call come in. We have an 11-year-old male hit by an RTA with a car at 80 kilometres per hour. He bullseye to the windscreen, bruising to left side of the chest with left upper quadrant bruising, open wrist fracture and open wound to the left forehead with crackles on auscultation. Pulse is 140, BP 84/60, reps are 24 and GCS is 14. They've given 600 milligrams of TXA and his ETA is 10 minutes.
Okay, so this is major chest trauma with hemorrhagic shock. We should put a trauma call out.
Okay, I can do that now.
Okay, trauma team, we have a major trauma coming in. An 11-year-old boy has been hit by a car at 80 kilometres per hour. He had a brief LOC at the scene, but his GCS is now 14. He sustained chest trauma and has significant bruising over the left side of his chest wall and his left upper quadrant. He also has crackles and auscultation, so we need to consider that he has a hemothorax and put a chest drain in. With that left upper quadrant bruising, he may have a splenic laceration and he's in hemorrhagic shock. He also has an open wrist fracture. So given the hemorrhagic shock, we'll start our resuscitation with blood, we'll insert the chest drain and we'll do the primary survey. He needs hemorrhage control to his head, he's got a head laceration. We need to consider activation of major hemorrhage protocol, just again given that hemorrhagic shock. We may need to do thoracostomies if he becomes hemodynamically unstable. If he does stay hemodynamically stable, then we'll be able to do our primary survey, manage the life threats and go to a CT. If he becomes hemodynamically unstable, then perhaps thoracostomies, a resuscitative thoracotomy, and also consider trauma laparotomy. As our assessment doctor, would you do the primary survey and feedback any relevant findings as you go along?
Yeah, sure. I'll be the assessment doctor. I'll do the primary survey and I'll feedback as I go along.
As our anaesthesiologist, would you manage the airway? At the moment his GCS is 14, but he has sustained significant chest trauma and is in hemorrhagic shock.
Yes, we will look after the airway. This is a complex trauma. I suspect we could see some changes in his status over the period of time and he may require intubation. As an airway nurse, are you happy to assist me and you're experienced in managing a paediatric airway?
Yes, I am experienced, yes.
Okay. We have everything ready and we will assist.
Thank you. Danielle, as our surgeon, would you insert a chest drain on the left-hand side? You have an advanced nurse practitioner with you as your procedure nurse. I think probably that you should prepare for bilateral chest drain insertion. If at any point the patient becomes hemodynamically unstable, then we'll need to do an emergency thoracostomy.
So we'll set up for bilateral chest drains, priority for the left side, with the risk of needing to do finger thoracostomies as well.
Thank you. Would you do a point of care ultrasound? We'll start with the lungs, just to see if there's bilateral lung slide, and do a point of care echocardiography as well.
Focused ultrasound I will do, and I will feed you back with the findings.
Thank you. Team leader support. Would you call the radiologist on call and let them know we're probably going to need a CT, and also the haematologist on call just in case we need to activate major hemorrhage protocol, that they are aware? And when the family arrive, would you update them and let them know whereabouts we are in our trauma resuscitation?
So I'll speak to the radiologist for a potential CT, potential to activate the major hemorrhage protocol and keep the family up to date.
Thank you. Circulation nurse. The patient has had a bolus of TXA 600 milligrams, but we need to start an infusion as soon as we can. So would you draw up the infusion and start it, and also can you send a trauma panel?
So send off a trauma panel and I'll set up a TXA infusion now.
That's great, thank you. For transfusion, we're going to need immediate resuscitation with blood. So would you draw up the first 10 mils per kilo of blood and give it immediately? Draw up the second 10 mils per kilo of blood, and while you're talking to the lab, just let them know again that we may need to activate major hemorrhage protocol.
I'll prepare and give the first 10 per kilo of blood. He is estimated at 40 kilos, which would be 400 mils. I'll prepare the second bolus and I'll liaise with the lab with regards to the major hemorrhage protocol.
Thank you. As our scribe, can you use the paediatric trauma doc as a record for contemporaneous note writing? And if you see anything along the way that needs to be addressed, can you feed it back to the nursing team leader?
Absolutely. So I'm going to use the trauma doc to scribe, and I will feed back anything omitted to the nursing team leader, Laura.
Thank you. And as our nurse team leader, can you support and answer any queries or concerns that the nursing team may have? And if you have any relevant comments, information or findings, can you feed them back to me?
Yeah, that's fine. As nursing team leader, I'll support and assist all of the nursing staff, and I will feed back all relevant information to you along the way.
Thank you. We're going to start our resuscitation with blood, so would you get the blood from the lab ready to go? And also, just thinking about the lethal trauma triad, we really need to make sure that the patient doesn't become hypothermic. So would you get the bear hugger ready to put on the patient as soon as we can?
So we'll get the bear hugger, then organise the bloods from the lab and liaise with the transfusion nurse.
Great, thank you. Okay, team, so we have 5 minutes till the patient arrives, so let's get all our equipment ready.
So if you wouldn't mind handing out these.
Now beyond this, some units of blood, okay?
That's great, thanks a million.
Thank you.
So if we just check these. And the second unit is again O negative blood. The expiry date is here. The number is R0001200525531, and again this is the expiry date here. Are we happy enough with that?
I'm happy with those, yeah.
Thank you.
Morning, just to update you, the patient's taken a rapid deterioration in the last 60 seconds. He's now tachy at 160. His resp rate is at 28. He's satting now at 30%. We did have bilateral crackles, and his BP has dropped to 52/36, and his GCS is now 7.
Okay, so that's a rapid deterioration. He's hemodynamically unstable. We need to do an immediate thoracostomy as soon as he goes onto the bed.
Okay, I'm ready.
We're just going to move you across onto the bed. Get the trolley locked. Quickly as possible. Tell me when the trolley's locked, guys.
Trolley's locked.
Okay, we're going to prepare to lift, and we're going to lift on 3. 1, 2, 3, lift.
Okay, please look at the back mat down, get the blanket off and expose the chest for the thoracostomy. This is our last breath at the moment. And we need to release the tension and take off the strap.
Right, so we're just going to give you some oxygen to breathe.
Okay.
Okay, clamp coming off. Okay, there's a lot of blood here. I'm just going to secure this.
So our TXA infusion is hung, is that?
TXA is gone on there now.
Okay, great. And is the blood ready?
It's almost ready.
Okay.
Trauma panel is sent.
Great, that's great, thank you.
First 10 kilo of blood is ready to go.
Okay, yeah, if you go ahead and do that, that'd be great. And Danielle, can you prepare for a chest drain on the right, please?
Not getting any responses. GCS is down a little. No blood in the airway. With respiratory effort is tachypnic but still at about 20. I'm going to move to front of neck assessment. Trachea is central. There's no surgical emphysema that I can palpate here. Can't really comment on the neck veins with the collar at the moment. Larynx feels central. I don't see any rupture. It feels okay in the centre. And I'm not seeing any carotid hematomas or swellings around the neck at the moment. I'm a little concerned that we're going to need to intubate here, especially given the hemodynamic instability.
If I have a line in the left right hand.
So is that's the first bolus of blood gone in?
The first bolus is just finishing now, yeah.
Okay, so our hemodynamics are improving, but let's start the second bolus of blood.
How are we going with the primary survey?
Moving on to breathing, there's the self-ventilating rest rate is about 20, and there's equal chest or symmetrical chest expansion. I don't see any sign of penetrating trauma, and there's a significant bruising of the left thorax and the left upper quadrant. Air entry is a bit down that right side. I'd be worried about another pneumothorax on that right side. And abdomen is soft and non-tender, pelvic binders in situ. I'll keep going.
Yeah, we'll need to get some trauma shears just to take up those trousers and make sure that there's no other long bone fractures. Danielle, can you insert a chest drain onto that the right side as soon as you can, please? Please. Okay, team, so we're putting a chest drain in and then we're going to intubate the patient.
Laura, can I get you to set the bear hooker?
Have we got a temperature check? I'm just very conscious about hypothermia.
And Laura, can I get the bear hooker on as well, please?
Okay. So tell me when the chest drain is in, and then we will commence the anaesthetic.
So we're 86 over 52. Our saturations are 98%. We're still tachycardic at 140.
Sats are
Chest
still
drain
okay?
is in.
Yeah. Guys, can we get an updated blood pressure, please? First, I want you to give us fentanyl, 1 mic per kilo, which will be 4 mils for him, for his weight.
Thank you.
His blood pressure's down a little, so I'm going to use ketamine, and I'm going to use 1 milligram per kilo, so that'll be 40 milligrams of ketamine, please. And we're going to use rocuronium for intubation, again at 1 milligram per kilo. Firstly, I want to commence inline stabilization. Are you in position?
I am.
Can you help me to remove the collar? Maintaining stability.
Collar is removed.
Very steady. We're now going to get ready. Paddy, you can start with the drugs.
Okay, I'm starting with the drugs.
Okay.
Fentanyl is in. I'm getting ketamine, 1 per kilo of ketamine. Rocuronium is in.
I'm going to wait 30 seconds and we will have paralysis. Okay, cricoid pressure is fully on. Steady, don't remove it at any point. Thank you, that's great. And now we're going to start.
30 seconds.
Okay, perfect. Nice and steady. Keep your cricoid pressure on, that's good. Cough up next, please. Put 3 mils of air in.
From a breathing perspective, I'm happy there's equal chest sounds on auscultation bilaterally and they're equal. Cap breath flow is 3 seconds. Abdomen is soft and non-tender. Still got that bruising on that left upper quadrant.
At the moment he's hemodynamically stable. He hasn't deteriorated. He may have a grade 1 or a grade 2 splenic laceration. Jennifer, have you spoken to a radiologist? They're en route. Okay, and we're just waiting on our first gas. And haematology are aware that we may be activating MHB.
Nuala, what would we give next? Do we want to give more blood or more saline?
Blood, absolutely.
Okay, blood.
If there is, we need to consider that this patient is acute trauma coagulopathy and activate MHP. So as soon as I get the gas back, I'll update you.
We're going to move on to the assessment of disability. Pupils are equally inert to light. They're size 4 millimeters.
Probably be here for a little while, Neela. How long before?
We're just warming up the scanner. They said it'll be about 10 minutes, but I think that'll actually give us a good time to continue stabilisation.
So good contractility, long slide bilaterally, and ventricular size is normal, and no pericardial effusion.
I have the blood gas results back there. So we have a pH of 7.25, a PCO2 of 5.4, PO2 is 3.9 with a base excess of minus 9.2, and a bicarb of 16.9, lactate is 6.3. There's also a coagulopathy, so a PT is raised at 18.5, APTT is normal, and fibrinogen is 1.93.
Okay, so we have a metabolic acidosis, so we have good evidence of hypoperfusion now. We also have a coagulopathy and a fibrinolysis, so he's gone into trauma-induced coagulopathy. We need to activate major hemorrhage protocol.
Okay. Can I activate the major hemorrhage protocol for the patient in Resus? Thank you.
Okay, so the primary survey is being completed. The life threats have been identified and managed. I think it's time to move on to the secondary survey. So would you mind starting the secondary survey? And actually, would you just begin with that open fracture of the wrist, please?
Yeah, no problem. Team leader, there's an open fracture of the left distal forearm, probably the ulna. There's no significant hemorrhage, and capillary fill in the distally seems normal.
Great, perfect. And Jennifer, would you call orthopaedics, please?
Yep. Okay, you're connecting the Hamilton C. 36.4. Okay. Octoplas has started.
Our third bolus of 10 reciprocal blood is gone in, yes?
Yes.
Great, okay, that's great. We'll get our platelets ready. Jennifer, can you just check if radiology are ready? And as soon as these products have gone in and the Hamilton is connected, then we'll start moving to Okay. Okay, trauma team. So in summary, we have a polytrauma. We had tension pneumothoraces and a hemothorax, which has been relieved, and bilateral chest drains have been inserted. The patient was in hemorrhagic shock. We've given blood and MTP. The patient is now intubated and the hemodynamics have improved. So the next step is to get ready. We're going to go to CT. So if we all start getting ready for transport.
Okay. Nothing pulling? No. Happy with that? Okay. Nice and steady now, Jimmy.
So Dr. Colleran, what does the CT show?
So the brain looks normal, Dr. Quinn, no significant findings on it. The chest drains are in a good position on the CT thorax. I was just finishing the abdomen there. The liver is normally attenuating, no liver laceration. There is a grade 1 splenic laceration with a little bit of perisplenic free fluid. The adjacent kidneys are normal and there's minimal free fluid in the abdomen. So overall then we're left with a grade 1 splenic injury and no other significant abdominal findings, and the duodenum looks normal.
We have a pelvic binder on, so is the pelvis normal?
The pelvis is normal and there's no fractures. We've looked at it on the coronal and sagittal bony windows as well, so there's nothing undisplaced there either.
That's great. So our hemodynamics have improved. We'll be able to go straight to ICU from here. Thanks a million. Team, we've just got the results of the CT. So CT brain is normal, CT chest, so the drains are in good position and draining really well. The abdomen shows a grade 1 splenic lac but no other solid organ injury. The pelvis is normal, so the binder can come off and there are no other abnormalities. So I'm happy that we're ready for transfer to PICU and surgeons are aware.
Break off. Okay. Nice and steady now, Jimmy. We'll go slow and steady.
Perfect.